Morning, all panelists and attendee members. I'm Sumit Saurav for Purvi Lab. I request Dr. Sumit Mandlik to start the session. Thank you and over to you, sir.
Uh,
Good morning. Thank you. Welcome all to this one more session of National Board of Education in Medical Sciences. This is a dedicated series on head and neck cancers. And I welcome Dr. Purvi, who is Senior Consultant at HCG Asta Cancer Center in head and neck. She is going to speak about a much important, very important subject, that is speech and swallowing in head and neck, because head and neck is so functionally important that any treatment in head and neck region is going to impact your speech and swallowing, which is one of the most important function for head and neck. So without much delay, I will hand over to Dr. Purvi. uh, Purvi, you can please start.
Good morning, everyone. Dr. Dushan Mandlik has already given my introduction. I am thankful to NBMS organizer, my moderator, Dr. Somshekhar sir, Dr. Kaustubh Patel, and Dr. Dushan Mandlik for giving me this opportunity. As Dr. Dushan Mandlik said, like this is a very important topic, but most neglected topic also. We surgeons mostly focus more on surgical part and we forget about the patient's functional outcome. So let's discuss this. It is a very small time period given to me, just a 1 hour, but I will try to accommodate all the topics in this. Uh, uh, Greetings from Ahmedabad. This is HCG Asta Cancer Center. It's a 200-bedded hospital, and this is our head and neck team. And because of this team only, we can focus more and more on good functional, not only oncological outcome, but the functional outcome of the patient. Now, we all know that head and neck cancer is a major public health problem and it accounts for 30% of all cancer cases in India. And as you see, Globocon 2020 has estimated increase in around 57.5% of cases by 2040. So around 9 lakhs individual every year are getting head and neck cancer. We focus more on the loco-regional control rates. We have a technological advancement. We give chemotherapy, radiation, and decrease the toxicity. Still, these patients, they definitely get some morbidity and some toxicities. If you are operating a breast cancer patient or a patient with GI, you won't see much from their look that this patient has been operated for cancer. But whenever you operate a case with head and neck cancer, either you go for surgery, radiation, chemoradiation, any of the modality, it will have a negative impact on the patient's treatment, post-treatment, speech, swallowing, respiration, and cosmesis. So these patients, they will have effects on their quality of life. They loses the function, ability to function in the society. They cannot, uh, they try to avoid going to the society, social functions, meetings, even at the offices. They are feeling some psychological depression. They have economic issue also. They cannot eat outside. They can even at home also when they have to eat, they just go separate and then eat. So if you ask your head and neck patients, you will see this is how the quality of life is affected. So before how we manage this, we have to understand what is the normal swallowing mechanism. So you all might be aware about it, but still let me just go briefly on this. There are 4 phases of normal swallowing. One is oral preparatory phase, second is oral transport phase, third is pharyngeal, and fourth is esophageal. In oral preparatory phase, what happens when you put a food in your mouth? The tongue start acting, it goes side to side, throw the food on the both side of teeth. The teeth chew the food, jaw movement gets involved, and the saliva gets mixed, and the bolus is formed. Once the bolus is formed, the tongue pushes the bolus towards the palate, and the oral transport phase starts. So this in this phase, the bolus is pushed backwards. Tongue base also gets involved, and then the pharyngeal muscles, they try to go to the pharyngeal phase. So in the pharyngeal phase, the soft palate goes upward, epiglottis goes anteriorly, cover the larynx, and the bolus is passed into the posterior pharyngeal wall, constrictor gets involved, and the food bolus is passed down to the esophagus or upper esophageal sphincter. And the peristalsis wave starts. The upper esophageal sphincter gets open, and the peristalsis wave further pushes down the bolus, and that's the esophageal phase. So this is all very rhythmatic fashion. It is happening, and it is controlled by the central pattern generator, which is located in the medulla. These phases are very important to understand when we are managing swallowing issue of our patient, and that's why it is very important to learn the normal physiology of swallowing. Similarly, what is the physiology of speaking? Like when we speak, not only our vocal cords are vibrating and produces the voice, the rest of the other organs are also get involved. So lung is the powerhouse. From lung we get a lot of source of air. When we expire, during the expiration, the vocal cords get vibrated. Then the pharyngeal part comes, pharynx, esophagus, they act as a resonator, and the tongue, lower lip, palate, they are the articulators. They are the generator of the speech. So this is also very important to understand the normal physiology of speech. Now, whenever we do, whether the patient is getting surgery or patient is getting radiated or chemoradiated, some of the morbidity will be there. So when we do surgery, there will be a loss of structures, like we remove muscle, we remove bone, cartilage. We do reconstruction with some adynamic flap. So if we do reconstruction with the local flap, usually the outcome is still better. But whenever we put a flap, either it is a regional flap or free flap, they are the adynamic segment. And that also impairs their speech and swallowing both. We cut nerves, there is a sensory impairment, motor impairment, and the sphincter dysfunction. So, in all the surgeries of head and neck, you get some kind of loss of structure and some impairment. Similarly, when we give radiation and chemoradiation, patient will have a mucositis, dry mouth. If there is no saliva, they will have definitely speech and swallowing issue. Sensory changes in their taste, smell, lot of fibrosis set in, especially when patients are taking radiation in the oropharyngeal pharynx larynx area. The muscles of constrictor muscles, they get fibrosed. They are very sensitive muscle, and that's why the patient, they develop stricture. Patient will have a painful swallowing because of the mucositis. They have edema, they have a lot of infection because the fungal and bacterial infection are common in post-radiated patient, and a lot of dental changes, caries and all. So all these are the complications, and all the side effects, they add into their uh, morbidity of dysphagia and speech. Now, how we are going to manage this swallowing and speech issue? There are 5 important steps to manage this. I will discuss about all the steps in detail. So first is prehabilitation. It's a new term, but yes, I will go in the detail of this term. Second is multidisciplinary team approach. Third important step is intraoperative or ongoing treatment management. So whenever you are operating a patient, or patient is sending for radiation or chemoradiation, that time you manage their swallowing and speech issue. The fourth is, once the patient has developed dysphagia, patient is suffering from some issues, and that you pitch in, that is called post-treatment diagnostic evaluation and the rehabilitation part. All these steps are very important. And if you follow all these 5 steps, patient's outcome will be so much different. Now, what is prehabilitation? Prehabilitation means before the patient starts treatment, you intervene. You start the rehabilitation before the treatment starts. And for that, treatment selection process is very important. You decide what kind of surgery you are going to do, what will be the site of resection, what will be the size of resection, what reconstruction will you give this to this patient, and how it is going to affect the speech and swallowing outcome. Similarly, if you are planning for chemoradiation, whether it is curative or adjuvant, how this radiation will be affecting, how much dose will be given, what areas will be uh, given the PTV, GTV. So this is very important when you plan and assume the functional effects of this treatment. The preventive therapy should be initiated before the treatment starts. You have to involve patient's caretaker. If you have a speech therapist in your team, that person should be involved. Physiotherapy should be involved, and some exercise should be taught to the patient before they go for the treatment. So there is a one Presto trial was initiated in 2020, and this has been initiated for patients who are undergoing for chemoradiotherapy, all head and neck cancer patients. And it is patients are taught 3 exercises: tongue strengthening, chin tuck against the resistance, and effortful swallow before they start the chemoradiation. And throughout the radiation, the exercises are being followed by the speech and language pathologists. And they have seen the quality of life and swallowing outcome is much better in patients who had undergone these exercises before. So it's called prehabilitation. Another randomized trial was done where the 5 prophylactic swallowing exercise were taught. They were taught every weekly or through the swallowing therapy session during the CTRT. And their results showed there is an improved swallowing function in the exercise arm at 3 and 6 months of follow-up. Not immediate. So see what happens when patient is having immediate effect of radiation, mucositis, xerostomia, swallowing difficulties. So that time you don't see the swallowing out. But yes, if the prehabilitation has started before, you can see at the end of 3 or 6 months, you can compare the results between those who are doing exercises and those who are not doing exercises. As I said, the second important parameter is multidisciplinary team approach. Not only the surgeons or radiation oncologists or medical oncologists, they are treating patient. You have to have a psychologist in your team. Dental rehabilitation team should be there. Pain management is very important. Speech and swallowing therapist, physiotherapists, they are playing very important role, and the dietitian who try to manage their nutritional levels when you are treating this patient. Majority of centers have an issue of finding a good speech and swallowing therapist. So if you don't have a good speech and swallowing therapist, you can train your physiotherapist, you can train your physician assistant who can help your patient in their rehabilitation and rehabilitation part. So it is very important to have a uh, multidisciplinary team for the management of speech and swallowing issue. Now, this is very important part, which where we surgeons can pitch in and we can give a good outcome to our patients so the swallowing and speech cannot be affected much. So, what we do? So, whenever we do lateral tongue resection, whenever we do partial glossectomy is just a 1/3 of a part of a oral tongue is resected. In that situation, if it is a lateral tongue resection, primary closure gives the best outcome, we all know, and with the best outcome in speech as well as swallowing. But we have to see when the partial defect is in the ventral surface of tongue, when it is on the dorsum surface of tongue, where you cannot do a primary closure. If you do a primary closure, patient's tongue length might not be maintained, patient's tongue get tethered, and the speech and swallowing outcome can be worsened. So, in such patients, you have to think about putting some reconstruction, some form of reconstruction should be done. This was a study done long back by Fred and all. Surgical variables affecting post-operative swallowing efficiency on oral cancer patients. It was a pilot study, and they have observed whenever we put the aerodynamic segment of flap, the speech and swallowing outcomes are not as better as like what it is in the primary closure. And if the resection of tongue is less than 30%, patient will have a good swallowing efficiency. So we all know primary closure is better, but then we have to think whether it is not going to tether the tongue and patient will have a good length of the tongue. Now, when we do anterior tongue resection, the anterior tongue, as you know, it produces such sound, t, th, d, th, n in our Hindi and some sound z in English. So, whenever anterior tongue is resected, patient will have some speech problem in producing this sound. Also, the as you know, anterior tongue is important to push the bolus backward. So, when anterior tongue is resected, patient will have a long preparatory time and the transit time. So, lot of food residue will be there in the oral cavity. And that's why whenever you do anterior tongue resection, it has to be done with the proper reconstruction. Whenever you insert a flap, it is very important you pull your tongue out like this and do your resection. Measure the tongue length which is affected, just not what the defect is there, tongue is just falling down in the mouth and you measure the length. You have to stick the tongue out, measure the entire length of the tongue and plan your flap accordingly. The goal should be whenever patient is post-operative phase, patient can stick the tongue out whenever you do the anterior tongue resection. That only will help patient for pushing the bolus posteriorly and swallowing issue will not be there. Now, when we resect the floor of mouth resection, lateral floor of mouth resection won't affect much because you just cut the mylohyoid muscle. In those situation, it won't affect the swallowing. But when you resect the anterior muscles, like geniohyoid muscles are resected along with the mylohyoid digastric, in those patients, the suprahyoid muscles are cut, patient will have a problem in laryngeal elevation. So just think about the physiology and mechanism of suprahyoid muscle. Whenever you swallow, the hyoid goes up, laryngeal elevation takes place, and then the pharyngeal phase starts. So in that situation, hyomandibular elevation should be very important when you do floor of mouth resection. Now, when you do a glossectomy, more than Hammy, kind of total glossectomy or near total glossectomy, preserving just a base of tongue, the flap inset, obviously that this type of glossectomy needs some form of reconstruction. The defect should be reconstructed with the bulky flap. It is very important. Even if you use regional flap, pectoralis major flap, you have to give a dome shaped reconstruction. You can't put the flap like flat like this, right? It is very important that you give a dome shape, though it is adynamic, it does not have sensation, but at least it will touch the palate when the patient opens the mouth. You can see your flap. It can touch your palate. If it touches your palate, patient's speech outcome is better and as well as the swallowing outcome. Because it is touching the palate patient can push the bolus downwards. So initially, yes, you might feel the defect is just 7 centimeter and I will take 7 centimeter. No, you have to take more flap. Anyway, you are going to do a tracheostomy in this patient. Let the mouth get filled with the flap, not an issue, because after the adjuvant treatment, it might get shrunken, and so the outcome might be different later on. So better to put a more flap when you are reconstructing the more than Hammy tongue defect. Sometimes we think if we have done a total glossectomy, should we do laryngectomy as well in such patients to prevent aspiration? Because this patient will have a very prolonged tracheostomy. But the studies are being done and they are not recommending doing total laryngectomy along with total glossectomy in patients because the speech outcomes are still better when you preserve the larynx. So if you have preserved a small part of base of tongue and reconstructed well with the bulky flap, patient's tracheostomy will be out maybe some time later, maybe 3 months, 6 months. But then their speech and swallowing outcome will be better. If you remove larynx, we have to do it. So in some cases where they are aspirating a lot, patient will have a recurrent pneumonia and all those things. There we have to sacrifice larynx also along with the glossectomy. And in that situation, patient will not have any speech. You cannot rehabilitate them with any speech, and the swallowing outcome will be better. Yes, you prevent aspiration by doing laryngectomy, but still better to do a proper reconstruction techniques used and do a laryngeal preservation. So whenever you are resecting a tongue base, more than 25% of tongue base is removed. Again, it is going to affect your pharyngeal transit time. And as I said, you have to do some good reconstruction. Now, mandibulectomy defects. So whenever we do marginal mandibulectomy, we have noticed patient won't have much speech and swallowing issues. Next day, you can ask patient to drink water; they will be comfortable. But whenever you are doing a segmental defect, and especially the lateral segment defect, there will be some issues with their swallowing. Initially, immediate post-op, they will not be able to swallow saliva properly. If you give water, they might aspirate. Gradually, they start getting adjusted to this defect, and segmental defects are still better than the central arch defect. So, whenever you resect the central arch of a mandible, you again your suprahyoid muscles are all removed, and the larynx goes down. So patient will have an issue with the laryngeal elevation. Whenever your segmental defect is more than hemi, right? So if it is crossing midline, in that situation, again the geniohyoid muscles are gone and the larynx goes down. So patient will have issue with the laryngeal elevation and patient will aspirate. We are doing tracheostomy in this patients, but then the tracheostomy lasts for long. And so very important that you have to do a laryngeal elevation. I'll show you the picture how to do the laryngeal elevation in this patient. Again, choice of flap should be very important. If you have a possibility of putting a free fibula flap in the central arch defect or lateral arch defect, the swallowing outcomes are best. If you don't have option of doing a free fibula flap, whenever you plan your regional flaps also, the way insert should be done, the patient will have a hammock kind of thing, and you hit your muscles to that regional flap muscles, and that will also improve your swallowing outcome. So here you can see the mechanism. With the proline stitch, you can put two small holes on the mandible, and with the proline, you can elevate your hyoid and take a stitch here. So you can see here in this picture, the hyoid is elevated and the bolus, foot bolus is pushed backwards. So pharyngeal elevation and laryngeal elevation helps improving the swallowing in this patient. We have seen patients that tracheostomies are even after central arch resection, near total glossectomy, if we have done a good hyomandibular elevation, even the segmental defects where your one-sided genio are gone, you can do a hyomandibular elevation with the remaining part of the one-sided. Only one-sided hyoid can be elevated, and the swallowing will be much better in this patient. Now, when we do hard palate resection, we all know patient will have oronasal or oroenteral communication. They will have a speech nasality. So immediate intraoral obturator processes, if you can plan, that is best. So you have to involve your dental team or your friends. So yes, this patients will require 2 or 3 processes needs to be changed. But if you give them immediate obturator processes, their swallowing will be better. The speech will not have any nasality. And yes, if you can reconstruct with any free flap or regional flap, that is the best thing. Now, we might have seen this kind of defects very often if we have done a soft palate resection, we have gone our composite resection posteriorly towards the tonsillar area, or patient has been radiated afterwards. So you can see this kind of soft palate defect, this patients will have a nasal regurgitation. And we see their speech is also have lot of nasality. So there are palatal birth processes available, but yes, it is very important. Your prosto department should be strong to plan such a processes which can cover this velopharyngeal deficiency. Uh, it's possible. The only issue is patients should get adjusted to this because this processes it touches the posterior pharyngeal wall, and so that's why the patient gets a lot of gag reflex. So it is very important that it has to be planned in a such a way that patient's speech is not affected and swallowing is also better. Now, when we do partial laryngectomy surgeries, I would say I would include here the cordectomy also. There is like we do in uh, partial resection of the cord. So in cordectomy, whenever there is a more than type 3 cordectomy is done, lot of muscle and arytenoids, part of false cord, they are resected. So in that patients, the speech and swallowing outcomes are little affected. Sometimes they require immediate post-op tracheostomy. Other partial laryngectomy like vertical hemilaryngectomy or supraglottic laryngectomy, patient will have some sensory and motor deficit because of the laryngeal mucosa loss. And it is very important that glottic closures should be continent to prevent the aspiration of saliva and food. So, whenever a patient who has already been radiated before doing surgery, you have to think whether this patient will be benefited with this partial laryngectomy or patient's life will be miserable with the aspiration of saliva and food. So, for this partial laryngectomy surgeries, experienced surgeon should be there. Glottic closure should be adequate whenever you do. So, like you have done a vertical hemilaryngectomy, the opposite cord should cover the reconstructed part on the contralateral side, and the glottic closure should be adequate. One-sided entire hemilaryngeal structure should be preserved, well preserved. Then only the glottic closure will be adequate. And all these patients, they need immediate tracheostomy in the immediate post-op period. And gradually, once they develop good swallowing, the tracheostomy should be weaned off. Now, whenever we do total laryngectomy, with some part of pharynx is resected, usually we tend to do a primary closure because like we don't want to do flap in total laryngectomy patient, and even if we want to do free flap, how to monitor those flaps. So in that patients we try to do just a primary closure. Yes, no doubt primary closure has a best swallowing outcome, but but you have to note that 3 centimeter of stretched non-radiated mucosa, sorry, 3 centimeter of non-stretched, non-radiated mucosa is sufficient for primary closure. Your stretch 8 centimeter mucosa is sufficient. Sorry, this is some problem in typing. So 3 centimeter of non-stretched, non-radiated mucosa should be there. Then only you can attempt a primary closure in the laryngectomy patient. And if you are stretched the mucosa, it should be at least length of 8 centimeter and non-radiated. Then only you can do primary closure. Otherwise, you put a patch, because if this patient, you're doing primary laryngectomy, patient is receiving radiation later on, then this patients will have a definitely stricture and patient swallowing outcome will be worst. Now, something about the tracheostomy. So, whenever you are doing a tracheostomy, we put a simple cuff tracheostomy. But I would definitely add to this that if we put a tracheostomy with the suction aid, this is a suction aid you can see, that helps in assessment of their aspiration post-operative phase. So you can just aspirate every day morning and see how much supraglottic aspiration is there in this patients. You can ask patient to swallow water and you can aspirate and see how much water is coming out with some colored dye or something, like you can just put a few betadine drops in your water and you can aspirate and see how much patient is aspirating. If patient is aspiration is gradually going down, then it is a time that you can wean off the tracheostomy. So whenever possible, use the supraglottic suction aid tracheostomy. Now we all know chemoradiotherapy. Whenever patient is undergoing a chemoradiation, it is very important we give pain relief so their nutrition can be maintained. The dietary modification is very important. Nutritionists should be involved in that time. So not only radiation oncologists just treat the patient, they should also involve the entire team whenever the treatment is going on. As I said, rehabilitation is very important when patients are going under the chemoradiation. Now, another important part is post-treatment diagnostic evaluation. This evaluation is usually done by speech language pathologists. But if we know, we have a knowledge, even sometimes we also can intervene and we can do the diagnostic evaluation of dysphagia. So, what you should do, we have to do the clinical evaluation. Once the patient has completed the treatment, patient has come to you, patient is having dysphagia. What will you do? You have to see the oromotor examination properly. What are the structures being spared? What flap has been done? What are the range of movement? What is the tone of a structure? Like how? What is the tone of the tongue? What is the strength of the tongue? We have to see the sensation patient is having, like palatal movement is there or not, hyposensation, what is the coordination when patient try to swallow. So all these things should be evaluated when they come with the complaint of dysphagia. Now we have to do voice assessment, four finger test. I will just go through all this list and then come in detail about this. Then repeated swallowing exercises, 100 ml water swallow test, and the food trials. So you can see when you do oromotor evaluation, we have to see the continence of the lip, whether they can puff the cheek, whether they can pout the lips, what is the tongue movement, right, left, lateral movement, whether they can push the tongue towards the sulcus, whether they can push the tongue towards palate. We can see the palatal movements. So this oromotor evaluation is very important when you see and identify which phase of swallowing is affected. Now, this is a four finger test. This can be done in the post-operative. Patient is admitted in the ward, post-operative phase. Patient is having little aspiration, coughing. You can just put a four fingers over here. One finger is over the cricoid, another one is over the thyroid cartilage. The third finger is on the hyoid bone, and the fourth is in the submental region. And ask the patient to just swallow the saliva. And in that, when patient swallow the saliva, you can just feel where the problem lies, whether they are not able to elevate the larynx, whether there is a oral lot of residue in the oral cavity, whether the suprahyoid muscles are not functioning. And that way you can judge what is the issue and you can start rehabilitation on that aspect. Now, what is 100 ml water test? So this is a very simple test. When you are suspecting any dysphagia, you give 100 ml of water to the patient and identify the cause of aspiration. So it is this water test is it's an early test to identify whether this patient will develop some limitations of the oral intake or not. Uh, Now there are a lot of objective evaluations you can find on Google and you can just have, but any of this should be there when you are evaluating your patient for the dysphagia. So there is a one functional oral intake scale. There is MD Anderson dysphagia inventory. This dysphagia inventory is like patient centric questions. Around 20 questions are there, and patient has to fill these questions. According to that inventory, you can judge how much swallowing difficulty patient is having. Scale, the penetration aspiration scale, which is filled by the clinicians. There is a dysphagia handicap index also. So any of this it can be utilized or a mix of this. when you are assessing your patient's dysphagia. This is going to give you a better idea how the patients are improving after the rehabilitation. So you can see this functional rehab. Uh, you can see here the pre-treatment and post-treatment outcome can be recorded, like patient is on tube dependent, there are three levels, or patient is having total oral intake. So they are level 4 and 7. You can tick on the pre-treatment level and post-treatment level. Then this is again MD Anderson. It is the short form is AMDADI score. And here you can see the 20 questionnaires are given. Whether the patient is the first question is for the global outcome, and rest of the 19 questions are for the composite outcome. So when we do a first question like patient swallowing ability limits my day-to-day activity, whether it is strongly agree or strongly disagree, that is the only one first question gives a global score, and the composite score is calculated. And if it is ranges from 20 to 100, 20 is extremely low functioning and 100 is very high functioning. This parameter is used when you are regularly following these patients every few monthly, and you can see their outcome. It is not like we have to assess only immediately post operatively, but after 2 months, after 4 months, after 6 months. And the speech language pathologist, they can work on it according to the outcomes or the score range. This is another index. So again, it is the some questions are repeated from the MDADI score. You can use this index also. This is a penetration aspiration scale. This can be recorded by the clinicians and they or the speech language pathologist, and they can record the score, how much aspiration is patient is having. Now, this is another instrumental assessment of dysphagia. Here, in this case, you can do a modified barium swallow technique or the fiber optic evaluation of the dysphagia. Now, when we do modified barium swallowing examination, we visualize the bolus flowing into the structures of the of the oral cavity to the esophagus. We can see the presence or absence of aspiration and at what level or at what time. It will help us to identify the cause of the aspiration, and also we can change the texture of our bolus, food consistency we can change, and we can do the test. So how it is function. So for that you need a special radiology setup when you want, because it is a real time investigation. When patient is swallowing barium, you should take a picture, take a video at that time. Our speech language pathologist, he is doing with the IITV, but it is done very routinely in our patients. So you can see this is a normal swallowing, barium swallow test. You can see again. So this patient does not have aspiration. Yes. So the patient is asked to drink a water and it has gone down. All esophageal, all swallowing phases are normal. Now, another patient you can see here is our own patient. Patient has been operated for base of tongue resection and tongue retraction is not possible. Patient's larynx is downwards. The patient's larynx is not elevated, and you can see the food residue over here. Patient is asked to swallow. Patients cannot initiate the proper pharyngeal phase, and you can see some aspiration here in the trachea. I'll play it again. So you can see the some aspiration. This is esophagus. And when patient is trying to swallow, the oral transit phase is affected, pharyngeal phase is affected. Yes, and this you can see patient is aspirating, patient had cough. So this gives us idea what is the issue. Now in such patients, I have not taken a video here, but if you elevate the larynx and ask them to swallow, in that phase, patient in that posture, patient will definitely not aspirate much because the larynx is elevated. So this gives us an idea how to do a video fluoroscopy or modified barium swallow examination. Another tool is FEES, which is like fiber optic endoscopic evaluation. So if you have the setup at your place, it can be done easily. We all know how to do fiber optic evaluation of swallowing. The only issue is if patient is having issue in the oral preparatory phase or oral transit phase, you cannot see in this piece. Only patient who are having issue with the larynx or pharyngeal phase, you can evaluate with the fees. And how much aspiration is there, the consistency of food, which patient can try, and then you can prevent the aspiration. So suppose patient is having chordectomy and patient is aspirating with the thin liquids, you can give him thickened liquids while doing the fees, and you can evaluate whether the patient will have aspiration or not. So this is how you can examine your base of tongue, your epiglottis. You can see whether the epiglottis is closing the larynx or not. Any food residue is there or not in the pharyngeal phase. Piriform fossas are filled with saliva, and sometimes with the upper esophageal stricture, you can see the food is spilling over the larynx. So that way, it gives us an idea about the level of dysphagia or what are the structures involved. We always have to think when we do a transition from tube feeding to oral feeding. And before doing that, I suggested all the scales, all this evaluation. It has to be done. You have to notice if patient is aspirating, how much is the spillage, and that way you can increase your safety of a swallow of your patient. So very important when you do a transition from tube feeding to oral feeding, do at least 100 ml water test. Now the fifth important parameter is rehabilitation. Rehabilitation is little boring part, but yes, if you learn this, if you don't have a speech language pathologist in your team, you learn this, you ask your radiation oncologist also to have a list of exercises, give it to patient, and you see your outcomes will be totally different. So now, what are the swallowing exercises and maneuvers which are recommended for dysphagia patients? So one is lip and jaw strengthening exercise. One is Mendelssohn maneuver, shaker exercise. I will go into this detail of these exercises. Supraglottic, supraglottic, Masako maneuver, range of movement exercises, effortful swallow. He is my speech and language pathologist in our team. Mr. Akshay Nayak, credit goes to him for making all this video because he's teaching patient with this video, right? So whenever patients having some lip movement affected, they will be drooling, and so lip strengthening is very important. You can ask them to do lip exercise in on everyday basis, 30 times repeat, morning, evening, this kind of exercises. So say E, stretch the lip. The second one is jaw opening and lateral jaw movement. You can see jaw opening as much as they can open the mouth. They can do some mouth opening exercise along with that, and lateral jaw movement, side to side movement, especially when tongue defects are there or patient is having reconstructed with the jaw. Side to side lateral jaw movements are very important. Now there are some assisted device also for lips, cheek, jaw, and tongue movement. Button pull exercise you can do. You can see on YouTube there are some variations are given for button pull exercise. The button and thread, patient can be asked to keep the button in between the lip and try to pull the thread. That way they can strengthen their lips. For chicks, you can give a variable size of straw, like rotated straw, like and some variations in straws are there. You can find it in a good this stores, and patient will have this kind of suction movement with the varied shape of straws, and that will help in strengthening their lip and palate and tongue movements. For jaw, there are a lot of orabite, terabyte jaw opening exercises, instruments are available. You can simply use the ice cream sticks. You can use the tongue depressor or spoon for the tongue exercises. Now, some exercises which is very important to learn. One is shaker. This shaker exercise can be taught to patient before starting chemoradiation, or if you are expecting patient is having some issue with the laryngeal elevation after the surgery. This exercise opens the upper esophageal sphincter, and the pharyngeal residue won't be there after the swallowing. This is a very simple exercise. You can see patient is asked to lie down in a supine position and elevate the head and try to tuck the chin towards the chest. So in this position, patient can be kept for around 1 minute and then again 1 minute relaxation. If they can do up to 10 to 20 times this exercise, this is going to really help them for laryngeal elevation. Another exercise is supraglottic maneuver. This is also very simple exercise. Here, we have to ask patient to take a breath first and then hold the breath, not to take a breath, because we have to separate the swallowing and the breathing both separately. So once they stop the breathing, ask them to swallow. Once the swallowing is complete, then only they can take the next breath, and that way it decreases the risk of aspiration. With the practice, they can definitely do this. You can see this. Now he has swallowed. You just cough it out if there is some residue in the pharynx, and then take a next breath. Then another one is supraglottic swallow. This is same as supraglottic swallow, but then you can ask patient to bend their neck and then swallow the food. So it will promote vocal cord closure. It will be tight closure of the vocal cord, and the pharyngeal residue will not be there, and patient will not aspirate. So you can see this. Patient again, ask patient to breathe, hold the breath, take a water swallow, bend your neck, and clear your throat, and then you again take a breath. So that way the aspiration can be prevented. Now, this is a Masako maneuver. This helps in again when patient is having reduced tongue-based movement, especially when oropharyngeal radiation has been given or patient is having tongue-based resection. This maneuver will should be started before surgery or before radiation. It should not be done with the food. Here, patient's tongue is stretched outwards and between the teeth. So you can patient will ask to stretch the tongue between the teeth like that. You can press it, then again push the tongue backward. So it will increase your tongue-based movement. But it is not advised to do with food because then patient will have a chance of little aspiration. Now, effortful swallow, this is very important. You can teach your patients, like whenever you go for the round, you teach your patients for constantly doing the effortful swallow. They should constantly swallow. This movement should be continuously done, and that way their muscles will start functioning. So, and when they do effortful swallow, all the structures, lip, cheek, tongue, pharynx, everything should get involved, and they should continuously doing this effortful swallow for the best outcome. Now, there are some compensatory strategies can be used, but believe me, that better to do exercises then you use the different consistency of food. Otherwise, no patient will tend to use whatever they like. So if they are adjusted with the thin fluids, they will just go for thin liquids. They will not try to attempt to swallow something. So, but yes, consistency of food can be tried, thick, thin liquids. Then altering the eating postures is also very important. If they change their head or body position, I will come to that also. Then also the swallowing is better. Sometimes like bite guide processes can help in patient who had a lateral segment defect. Pitchku bottle. This is also we have tried in many of our patients. With Pitchku bottle with the long nozzle, when they press the Pitchku bottle, they can just omit the oral transit time. So, in when patient is having anterior glossectomy defect, lateral segment defect, if you use them and the base of tongue is functioning well, you use the Pitchku bottle, the swallowing is much better, and they can take thick liquids also. with the Pisco bottle. So head positioning is also very important. This exercise, chin down, chin tuck when they are swallowing, head tilt right or left lateral is also help them, and head back when they are having more oral transit time. You can use this position. So with the head back posture, you can see they can clear the bolus through the gravity. It will go down and there is no aspiration. When they tilt the head on the stronger side, the head should be tilted on the stronger side so the food bolus can slide from that side and you can avoid the weaker side. Education to the patient is very important. Patient's caretaker should be given a proper guidance regarding the swallowing exercise, dietary modification. Let them get involved in their rehabilitation and obviously our team. So, as I said, speech language pathologist is very important. But if you are not having any pathologist in your team, you can train other people, your radiation oncologist, your physician assistant. Now, something about speech. This I covered, try to cover all the swallowing part mainly and also the speech part. Something about post laryngectomy speech. You might get such question also post laryngectomy rehabilitation, speech rehabilitation, maybe a short note in your exams. So, speech is a civilization itself. The word, even the most contradictory word, reserves the context. It is silence which isolates. So, with this quote of Thomas Mann, we have started a practice that any patient who is undergoing laryngectomy should be rehabilitated with some kind of speech, whether it is esophageal, whether it is TP or it is electrolarynx. But there should be some kind of speech given to this patient. So the rehabilitation of speech started way back when the first laryngectomy was done by Bill Roth. Now, before going for speech dysfunction, you again do oromotor examination, endoscopy, stroboscopy, voice handicap index can be evaluated. Uh, if patient is having vocal cord paralysis, then you can do some thyroplasty kind of treatment. But very important, if patient is having vocal cord paralysis, wait for some time. Usually the time it is said like you can wait till 9 months or 1 year. And if there is a no compensatory mechanism happening, patient is still having bad voice, you can go for some kind of surgery for the vocal cord paralysis. And it might be required after neck dissection, ME or total thyroidectomy, where you have expected some neuropraxia, nerve damage, or more than type 3 cordectomy. So, what rehabilitation can be done in this patient? If patient's vocal cord is lateralized, you can do some injection thyroplasty. Then celastic block can be used for the thyroplasty. Then arytenoid adduction can be done. Just a suture is taken to pull the paralyzed vocal cord in the midline. This can be done in patients who has undergone chemoradiation also. So their vocal cord is adducted and not medializing. That time also you can use this procedure. But as I said, wait for 1 year, then only you can do. And laryngeal innervation surgery can be done immediately after the damage to the nerve. So if you have done a thyroidectomy, your nerve is damaged, if your plastic surgeon is there, you can just ask them to re-innervate the nerve. If possible, you can re-innervate the cricothyroid muscle also. And that way you can give a good rehabilitation of this patient. Now something on laryngectomy, as I said. Now, when patient undergoes laryngectomy, patient has three modes of speaking. One is esophageal speech, another one is artificial larynx, and third one is tracheoesophageal puncture. In esophageal speech, there is no instrument required. Patient just practices, they gulp the air inside the neopharynx. They vibrate the neopharynx with the gulping of air and the sound is produced. So you can see this patient. You can see in this patient, they there is no special procedure required, no additional cost, no fistula, no aspiration, socially acceptable speech. But the issue is they need a lot of practice to develop the speech. Air capacity of gulping the air is very less, just 80 ml. And so phonation time is only 2 seconds. So they have to speak few words and they have to gulp the air in between. Maru, Nam. So before speaking each word, they have to gulp air and vibrate. So only thing is practice, practice, and practice is required in this kind of speech. The second speech is electrolarynx speech. Again, there is no special instruments are required. Only one electrolarynx patient has to purchase. With the electrolarynx, they can identify the vibratory segment on the submental triangle or submandibular triangle. They vibrate the organs like residual tongue, some muscles, the pharyngeal mucosa, and they can produce the speech. The issue is the speech is like a robotic speech, but still, if they are well trained, they can communicate, and it is a socially acceptable speech. So you can see, yes, robotic kind of voice is there, but it is easy to use. The battery is also like rechargeable. There, it should be started immediately after 3 weeks of surgery. And so speech acquisition is very rapid in this. No risk of fistula aspiration. No special procedure is required. There is no much cost involved, one-time investment of electrolarynx. And if they are trained well, socially acceptable speech they can produce. Now, the third speech is tracheoesophageal puncture and then putting a prosthesis. So here you can see this is a party wall between the trachea and the esophagus. And the puncture is done here and the prosthesis is put there. And patient can have a best speech outcome with the tracheoesophageal puncture. Sorry. Second June 2007 उसके बाद आज तक आपको बोलने में कोई प्रॉब्लम जब तक रेडिएशन नहीं हुआ था तब तक रेडिएशन के बाद भी डर लगता था कोई प्रॉब्लम नहीं तो आपने बहुत सपोर्ट दिया मुझे आपने बोला कि मेरे सारे पेशेंट बोलते तो आप तो नहीं बोलेंगे वो बात उसके बाद मैंने स्पीच थेरेपी 2 महीने जब so you can notice the speech outcome with the TEP speech is much, much way better. But yes, it is not without any complications. Whenever you put a TEP processes, there are some kind of problems will be there. Patient will have a recurring cost. Then changing of a processes, timing when to do the TP puncture. These are all very important, which is out of scope of this lecture. So, but these are very important points which we can, I think I can ask Dr. Dushan Mandlik and Somsekhar sir to schedule another lecture on this, how to rehabilitate patient with the TEP speech. Now, way beyond this, like when patients speak with the TEP, they have to put a thumb over here on the stoma, but there is a hands-free processes. Hands-free processes are also available, and hands-free devices really help. So you can see this video. ઓપરેશન પછી વાલ બેસાડ્યો હતો ત્યાર પછી બોલી શકાય છે હવે આ ખોલીને તમારો વાલ બતાવો તો વાલનો એરિયા છે. So this patient is using the hands-free device. He doesn't need to put the thumb on his stoma also. There is a Larry button. Okay. And with that hands-free, he can speak. Even the speech quality is super. In the market, there are 3 types of processes available. One is Blomsinger, the second one is Provox and Ohm. I prefer to use Blomsinger because there are a lot of variation in sizes of the Blomsinger is available. and lot of varieties are available. So according to patient's need, I can choose one processes out of this. Speech quality is good. Patient's phonation time is very lengthy. They can speak entire sentence. Yes, need to close the stoma, but as I said, now there are hands-free devices available. The only thing is surgical skill is required, frequent change of processes, recurring cost, and when the processes fails, patient will have some aspiration and some complications need to be managed when we are using this, like candida colonization, infection, false track, extrusion of processes. These are all expected processes related issues, but we can still troubleshoot all the problems and we can give a good speech outcome to this patient. There are two types of primary and secondary tracheoesophageal puncture. I prefer to do primary TEP because it is done at the time of laryngectomy. You can start speech rehabilitation after 3 weeks, and patient does not need to go for under general anesthesia. I think in the majority of surgeons who are doing this primary TEP, they doing TEP, they prefer to do in the primary setting only. This is just to give you an idea about the cost of TEP. Like it costs between 30 to 45,000. But yes, recurring cost, but the speech is very good. So, uh, in nutshell, I will just tell this that whenever you see a patient, think about the speech and swallowing outcome and try to rehabilitate, try to rehabilitate, keep some indexes with you, involve your team, and give a best speech and swallowing outcome. You can definitely do it. Now, any questions? Questions?
Purvi, excellent lecture. You have covered almost all regarding speech and swallowing in detail. Very important, uh, practical wise also. And whenever the trainees will go and practice, these are the important issues that they should keep in mind. I'm not able to see any questions in the chat box.
Yeah. Any questions from the participants?
So I think there are no questions. Uh,
I think I
it,
think they
it's
understood it
it's
well, or
it's so
maybe it
clear.
was boring.
It's so clear that you have made them understood everything. So over to NB.
Yes, sir.
Yeah, so there are no questions, and we can conclude the session.
Thank you. Thank you.
Okay. Thank you, everyone.